Hi, my name is Dr. Carlos Wesley. My practice specializes exclusively in hair restoration and hair restoration surgery, but today I'll talk about a relatively novel treatment for treating androgenetic hair loss using the patient's platelet-rich plasma, or PRP. It's a safe autologous cell-using procedure, and it's relatively easy to do. And for those reasons, I can tell you it's popping up all over the nation. Many different clinics are offering PRP for hair restoration, not just hair restoration. Lots of different skin procedures involve PRP. In fact, it's gotten to the point where PRP is the solution for all problems. Well, it's been around since 1975. At least 1975 was the first medical-related publication. It was used for corneal transplant procedures rather than sutures. They use PRP as a physiologic adhesive. In dentistry, it's been used to regenerate gums and osseous regeneration, pesky ulcers that aren't otherwise healing, large-scale burns. PRP can help with repair of those. In orthopedics, it's an adjuvant for rotator cuff surgery, osteoarthritis, and in sports medicine, of course, tennis elbow. This is a treatment for tennis elbow. But it was in 1996 when the first hair-related publication came about, and it just indicated that platelet-derived growth factor can have a positive effect on hair canal formation. But recently, of course, in cosmetic dermatology, it's been shown to enhance your Kim Kardashian. And so, of course, at this point, it's very much in the public eye, and we've been down this path before. In 2010, it had been very popular in orthopedics, but a New York Times article came out that showed that maybe the bubbles burst. It may not be the most ethical treatment if it's not necessarily a guarantee. In fact, it was shown to be, in some cases, no more effective than saline. So clearly there's limitations to PRP treatments, and that's what we want to focus on with this talk, really figuring out those limitations and trying to overcome them so you can really perform the optimal procedure with each of your patients. And we'll talk about the technical aspects of actually performing the procedure. We'll talk about ways to give patients realistic expectations so the benefit matches what they had envisioned, and really trying to select the best candidates for PRP treatment. In our world, the world of hair, we started listening in 2004. There was a doctor from Brazil, a plastic surgeon named Carlos Uibel, that came and presented at a meeting in Philadelphia his findings for how PRP helps enhance the results from hair transplantation. Now, traditionally the way hair transplantation works is you take hair from the back of the head, the donor area, move it to the recipient area, where there's some thinning, and the hair grows in the new location as it would have in the original location. So what we traditionally had done is we take out a thin strip of hair-bearing skin, divide it up under the microscope into follicular units, grafts, micrografts. We use those terms interchangeably, and those are subsequently transplanted into tiny incisions that are made by the surgeon. Now what Dr. Uibel did is, prior to transplanting them, he stored the grafts in the patient's PRP and incubated them for a while. He wanted to see how that would impact the survival rate of the transplanted hairs. So how did he obtain the PRP? Well, you just do a blood draw, and taking advantage of the different size and weight of the cell types in your blood, you can centrifuge, do 2 spins in order to isolate the platelets. And storing the grafts, some of the grafts were stored in the patient's platelet-rich plasma, some were stored in saline before being transplanted into small incisions. What he did then is he made 2 tiny squares into where the grafts were being placed. On the right-hand side, the grafts that had been incubated in the patient's PRP were placed. On the left-hand side, it was their saline-soaked counterparts, grafts that were just stored in saline. 7 months later, the patients came back and he did hair counts. And what he found, and this was an N of about 20 patients, there was a statistically significant improvement in the survival rate of the PRP-soaked grafts versus those that were stored in saline. About 20% more of the grafts survived. In addition, the caliber, the thickness of the transplanted hair follicles was significantly greater when they were stored in the patient's PRP. Well, then I started incorporating that method into my own practice. I can tell you that traditionally what we had seen is it's about a year before you can appreciate the full effect. Around 3 months, patients get frustrated because they don't see much of a difference. So the pattern is designed, and about a year later is when it translates into hair growth. Even 18 months after the procedure, there's newly transplanted hairs growing in for the first time. So it's really about 2 years after the procedure that people can really get excited about the full effect from the procedure. Then we started using PRP as a holding solution. And we started to know something very interesting. We started to see how at 6 months, patients really started to show almost the full effect. And we started seeing these types of results at 5 months. And then it was crazy. We started seeing them as early as 4.5 months, and it didn't make sense. We weren't transplanting that many more grafts into the recipient area. And what we realized is that the PRP in which the hair follicles were stored, the transplanted hairs were stored, when they were placed, the PRP was transmitted to the surrounding hairs, the pre-existing hairs, and having a really positive effect on the native hairs that were there. So then, of course, we wanted to try it out just injecting it. So we did the same thing. We drew blood, spun it down in a centrifuge, captured the platelet concentrate right here, and then we injected it into the scalp. Lo and behold, it worked. It was great. This is one of my original patients, and we saw how the miniaturized hairs really started to grow. We were thrilled. The next patient was inquiring about it, and I said, sure, let's do it. He had thinning in his crown, treated with PRP injections, and it worked. The hair looked certainly better after a couple months. Now, granted, the lighting is a little bit different in this video versus the one a couple seconds later, but we had our magnified camera that was able to track the changes of the scalp. And first we saw the scalp condition improve, and then once we saw that, the hair thickness, the caliber, really started to come in. We felt great. It was going to work on everyone, no doubt about it. So we started recommending it to patients, and then what happened is a couple months later, patients came back and they really didn't see a whole lot of difference. And I felt like a bit of a charlatan because I didn't see much of a difference either. And then I pulled out my magnified lens, and sure enough, we couldn't really see what was different. We couldn't really find the same spot in the scalp, and I didn't really appreciate much of a change. So we had to sort of go back to the drawing board. I needed to figure out how I can improve the way that I perform the procedure. And the first thing, quite honestly, was just having a better understanding of what's going on. Understanding the mechanism of how PRP positively impacts hair growth would help me then start to tweak the different variables, the different technical aspects of performing the procedure. And finally, it was important to be able to really accurately measure hair change. It's important with hair because hair grows only about 1/2 inch every month. So if we can start to track changes early on, then we can confidently tell patients that they can see for themselves that new hair is coming in, but it may not manifest itself as fullness in a bathroom mirror for maybe 3 months down the road as the hair starts to come in. So how does PRP work? Well, platelets are floating around in your body. There's 2 different forms of platelets. There can be platelets in the resting phase and then in the active phase. They're the very first cells to arrive at the site of tissue injury. Once they are activated, and they're activated by coming in contact with damaged endothelium, they can be activated by chemicals such as calcium chloride or thrombin. Once the platelets are converted into their active form, they release growth factors that are stored in different granules, primarily in the alpha granules. There are about 300 different known growth factors that are released by alpha granules of platelets. Those set off a whole cascade of effects. Again, there's about 300 defined growth factors that can be released by alpha granules, and we'll go over each of them one by one. They're fascinating, and how they interact with each other. Platelet-derived growth factor upregulate. No, I'm just kidding. We won't do that. But what we will do is we'll simplify it and show how the effects of growth factors can impact the dermopapilla cells. And these are the most important cells when it comes to hair. Now this cell here, this big mound, is a DP cell, a dermopapilla cell. And in the world of hair, dermopapilla cells are located here in the bulb of hairs and in the hair bulge. These are those 2 stem cell containing colonies, and they need to communicate for the hair to keep on regenerating throughout a patient's lifetime, and also to rev up the growth phase, the anagen phase. So we're in this region of the hair follicle right now, the DP, the dermopapilla cell. What we'll do is, it's been simplified in this paper by Gupta. The growth factor receptor is just a generic receptor. Again, there's about 300 different types of growth factors, but when the growth factor comes in contact with its specific receptor, it activates something called protein kinase B, also known as AKT, which in turn phosphorylates different molecules that are pro-apoptotic molecules. Apoptosis is cell death. And so by phosphorylating these pro-apoptotic molecules, apoptosis is halted, cell death is halted. Phosphorylation renders them inactive. And so what that allows then is it allows for beta-catenin to enter the nucleus. It changes the gene expression of the DP cells and allows them to differentiate and proliferate. Also, the angiogenesis is enhanced, and the anagen phase, the growth phase of the hair follicle, is prolonged. So we oftentimes think of PRP stimulating hair, growth factors stimulating hair, but in reality the primary mechanism seems to be the decrease in apoptosis. It slows and even stops cell death, and it's done in a way primarily by this magical molecule called AKT. AKT, well, coincidentally, my wife, Anna Kaiser, owns a phenomenal exercise company, a dance-based fitness company called AKT in Motion. So for those of you that are in the mood for a phenomenal workout, there's studios throughout Manhattan, East Hampton, Connecticut, and soon opening up in LA. And Target has made Anna one of their fitness ambassadors, and for a limited time, Target has launched an Anna Kaiser line of clothing available in hundreds of Target stores throughout the nation and online. So you can enjoy that. Now back to hair. PRP's effect on the hair follicle, what it does is it stimulates cells in this area, prolonging the growth phase. And that's something, prolonging the growth phase can give more fullness simply because hair is a tapered structure. It's thinner at the tip than it is at the base. So by having the hair grow out, the caliber, the thickness of each hair becomes a bit greater. And if you increase the caliber, the thickness of every hair follicle, not by a millimeter, but 0.01 millimeters, it can increase the overall coverage, the overall volume of hair by about 38%. So that's one element, and also it increases perifollicular vessels. It increases circulation down at the base of hair follicles. Now we can see in theory that PRP can have a positive effect on hair, but how about in reality? What have different clinical investigations shown? Well, there's a whole bunch of them. If you do a PubMed search or a Google Scholar search, you'll see hundreds of PRP articles in medicine. If you focus on just androgenetic alopecia or genetic hair loss, that number is less. There's maybe in the 20s. What I did is I pulled about 19 different studies, reviewed them, and then organized them into those that really seemed to have where PRP had a clearly positive outcome on genetic hair loss versus those studies where it sort of was inconclusive. The benefit really wasn't that clear. So what we'll do here is I'm going to try to compare apples to apples. The question is, does PRP work for treating androgenetic hair loss? And we'll go through all these and we'll try to have that answer, but the way that we do that is by comparing apples to apples. So the first thing I'll do is I'll start eliminating studies that maybe don't answer that direct question. We have to be able to compare PRP not just with baseline, but with the placebo control. So that leaves us with 6. There are 6 studies that seem to compare the benefit of platelet-rich plasma injections into the scalp versus injecting placebo. Now, 2 of these studies came out towards the middle or end of 2016, and I'll go over each of those, but the problem is there was a meta-analysis that looked at these 4 studies. The meta-analysis came out in 2016, and it looked at these 4 studies, pooled the data. There were about an N of 60. There were 60 patients that were evaluated, and what they looked at specifically is hair density. And what they found was overall, with the hair density change in these studies versus placebo, there was a standardized mean difference of 0.51 with a 95% confidence interval. All of them were positive, and what this suggested was, yes, indeed, PRP can be an effective treatment for genetic hair loss. Now, notice that 3 of the studies were in the positive column and 1's in the inconclusive column. Well, the one that's in the inconclusive column is right here. And one of the differences is just simply whether or not the PRP was activated. In this study, where the results were really not that impressive, the PRP wasn't activated. And so that may be one of the secrets, and we'll go through all these factors to really figure out what optimizes the chances of PRP working. These more recent studies by Alves in 2016 and by Puig in 2016 had very different outcomes. Here, there were statistically significant improvements with PRP treatment over the placebo. Here, it was found that PRP works about as well as saline. However, there are differences in the way that the procedure was performed. In this study, with the positive outcome, the PRP was activated. In this study, the PRP was not activated. In this study, there were 3 PRP treatments spaced 1 month apart. In this study, they just did PRP once. In this study, they did not use lidocaine to numb the head. In this study, they did. Looking back at the study that didn't work, the one by Puig in 2006, when they were interviewed, patient satisfaction was greater in the PRP treated population. They noticed more hair fullness and an ease of styling of their hair, which is something that they didn't appreciate in the population where saline was used as a placebo. Now, what's involved in this procedure? I mean, how complicated can it really be? You're just drawing blood and injecting it. Well, there's many different steps involved in the process. Patients come in our practice, we draw about 60 cc's of whole blood, prep the scalp with an antiseptic solution, do a numbing block in the forehead region. Meanwhile, in the other room, the whole blood is spun down. There's two centrifuge spins. The first isolates the erythrocytes, the red cells, separates those. Then we have the platelets and leukocytes. We do a tighter spin that just isolates the platelet pellet. Meanwhile, in the other room, I'm numbing after I've numbed the top of the head, I do a microneedle stimulation. And then I'll do about 25-30 injections of PRP into the scalp, usually the subcutaneous plane. Patients don't feel this. It feels like they're wearing an invisible helmet. And we'll do about 25-30 injections and then follow it up one more time with another pass of the microneedle for stimulation. Now, it takes about an hour, 45 minutes. So in that simple procedure, there's a lot of different variables that may come into play, having a positive or negative outcome on the hair growth. There's the way the blood is spun, whether or not we're using lidocaine, how the PRP is injected, the concentration at which it's injected. Should we use microneedles or not? How old should the patient be? What's the concentration of the quantity of blood that we should use? What's the caliber of the needle? Should we use an extracellular matrix in our PRP? Well, I can tell you, I'm not a big fan of the city of Las Vegas. I don't love going there, but a lot of my friends really do. I can also tell you, if one of my best friends were a professional card counter, and I knew that every time we went to the card table, and he were with me, and he would tell me to sit down at only the perfect time when we almost knew that we were going to win, or at least optimize our chances, I'd go there every weekend. Well, the goal here is to try to set you up the same way, optimizing all the different variables in order to improve your chances of having a successful outcome with PRP. So we'll go through them individually, real quickly. Centrifugation, the way the blood is spun, well, it can be a single spin process. There's lots of commercially available kits where you can just draw blood, give it to the kit, and it isolates PRP for you. We use a 2-spin process, a manual 2-spin process in our office. And the reason why I like to do that is I do feel it gives a higher concentration of platelets when it's all said and done. What we do is the following. Whole blood's taken, spun down the first time. These are the red cells, and this is the supernatant with platelets and leukocytes. So we take all the supernatant, respin that, and then we get sort of the treasure here, the platelet pellet. You can see the little white pellet at the base of each test tube. Those are the platelets. We resuspend all of those, and this is what we get. Now, you can see in the video when I'm injecting, we do have a few red cells, and there's probably a few white cells. I include that because we want to capture as many platelets as possible. And so in our final injection, we probably have about 5 cc's of PRP, anywhere from 5 to 6, and there's about 5 to 7 times the platelet concentration, but it is pure PRP, a high concentration of platelets, and we try to minimize the amount of leukocytes. Well, what concentration is ideal? I can tell you in some studies, they talk about a concentration of PRP that should be 2 to 6 times the native level. 2 to 3 times is just not enough. The studies that had the not nearly as impressive outcomes had PRP concentrations that were 2-3 times the physiologic level. That's not going to cut it. You want to have about at least 5 times the physiologic concentration of platelets, ideally 5 to 7 times, in order to have the effect. It's been shown that you want to have at least 1 million platelets per microliter to stimulate angiogenesis. And some studies have shown you want to have 1.5 million platelets per microliter in order to really have the optimal effect. So you at least 5 times or more the concentration of platelets versus what's in your whole blood. Now, how should you inject it? There's a lot of other factors. Should you use a numbing medication? Should you use a larger caliber needle or something just to make it more comfortable? Well, you have to really balance patient comfort with the efficacy of the procedure. Looking specifically at lidocaine, there was a study, and this was mainly looking at the orthopedic use of PRP, because in ortho, oftentimes what they're doing is they're introducing the numbing medication, the lidocaine, into the same cavity as the PRP is being introduced. So in this study, they looked at PRP being incubated with lidocaine at 37 degrees centigrade for 72 hours. They then took the samples and they passed it through a machine that measures the platelet's ability to bind, to aggregate. It's called light transmittance aggregometry. This is the control, and this is the control. The control has just platelets being incubated with phosphobuffer saline, with saline. Here the platelets in PBS are with collagen, but this is a control and this is a control. You can see this is the platelet's ability to aggregate, to bind, which is an indirect measure of activation, platelet activation. You can see when lidocaine is added, the ability of the platelet to be activated or to aggregate here decreases. But when lidocaine is added with epinephrine, the aggregation percentage increases. It seems to upregulate activation. That's been shown as well physiologically. Epinephrine can have a positive effect on platelet aggregation. Over here, when collagen's in the mix, this is the baseline, this is your control, and then when you add lidocaine and incubate that with PRP, the platelets don't aggregate as effectively, and therefore they're not as activated by their interaction with lidocaine. Interestingly, when epinephrine had the opposite effect in this case, and I'm not really sure how to interpret that, but what I can say is that when it's incubated with lidocaine, it seemed to decrease the platelets' activity. Now again, this is when you're incubating PRP with lidocaine, which is not what we do in our procedure, but it's still an interesting study. Then they looked at the growth factor percentage using the same sort of model, and they found that lidocaine didn't really have much of an effect on the amount of growth factor that's actually being released. 30 gauge needles were also investigated. They wanted to see if there's an impact on the size of the needle in which the PRP is being introduced, and if that activates platelets. There was no significant finding. They used 30 gauge needles and there was no significant change in platelet activation. The significance of platelet activation is the following. 70% of growth factors, the pre-synthesized growth factors of platelets, are released really within the first 10 minutes. 95% of pre-synthesized growth factors are released within the first hour of activation. So you're getting a large dose up front immediately upon activation. Now the platelet's lifespan is really about 10 days, and so the platelet still continues to synthesize growth factors and release them, but once it's activated, you get a quick bolus of the pre-synthesized growth factors. Some of these, actually the best activation studies are done in equine medicine with horses, and you can see here the platelets are in their resting form and then they're in their active form, and what they're using is either calcium chloride or a thrombin solution to convert a higher percentage of platelets into their active form. And so that was one of the trends in looking at all these different studies. One of the trends was there was more improvement, a marked improvement in patients that had activated platelet-rich plasma introduced into their scalp over the patients that had non-activated PRP. So that is one of the elements that I do think is important. And also adding an extracellular matrix. We do add Acell, we blend that with our PRP. The theory behind that is it prolongs the release of growth factors. Combining the two, you have an earlier release, an earlier activation, and a more prolonged activation. Some people would say those are two countering philosophies, but overall, my opinion is you just want more. You want more growth factors, so more up front and more for a prolonged period of time. Microneedling, the next element of the procedure, is something that I do think is important. You saw in the video we use a micro roller, but now what we actually like to use is a derminator, and the reason why we use that, it's a microneedles attached to a machine, and with this machine you can actually set the depth of the microneedling. The reason why I like to do this is because we like to set it to about 1 millimeter or 0.75 millimeters. Hair follicles, and this was a study by Francisco Jimenez years ago, to identify where along the hair follicle stem cells reside. He found they're present all along the follicle except for this 1 millimeter stretch before the hair exits the skin surface. It's sort of a dead zone up here. So I like to set the needling device so I can stimulate this area, create sort of a fake trauma, activate a growth factor cascade without causing any structural damage to the stem cell containing portion of the hair follicle. Does microneedling do anything? Well, yeah, it really can. There was an interesting study that looked at patients that use minoxidil twice a day versus patients that use minoxidil twice a day and once a week did a little micro roller on their head. And what they found is a statistically significant increase in the number of hairs three months later of the patients that had been doing both the weekly microneedling and the minoxidil twice daily. Also of interest, they saw those same patients back about 8 months later, and the patients that had been doing the microneedling had a more sustained benefit from this intervention. 8 months later, they still had their hair improvements, whereas patients that didn't do the microneedling, the benefits started to fade. You should do PRP more than once. Studies that use just one PRP session really didn't seem to have great outcomes. If you do it 2 or more times, those are the studies that showed the best outcomes. It has nothing to do with patients' change in libido. This is talking about gender, and what it showed is that women seem to have more improvement than men, looking at density and caliber. So there was an article in the New York Times about 2015 that featured PRP as a treatment for hair loss in women, and it featured our practice. And as a result of this, we certainly had an uptick in the number of patients that wanted to come in and learn about it. And so since then, we've had a very significant number of patients come in for PRP treatments, and quite honestly, we've learned along the way. We've modified our technique as we've seen patients respond differently, with each variable being optimized. It's something with shiny bald to coverage. Some patients have an increase in the melanocytes, the coloration of the hairs coming in. Where there's miniaturized hairs, there can be a benefit to the PRP. Coloration come back, the hair can become longer, thicker, fuller. It's subtle, but it certainly can have a nice effect in areas where there's miniaturized hair. Some people use it to touch up certain areas. Sometimes it can just be an overall increase in volume. Patients that I think are great candidates for surgery sometimes do PRP and respond very well. Again, some people really are too young for surgery, but can benefit quite greatly from PRP treatments in order to have more fullness. This is a patient who had a bad transplant someplace else, but then when we did a PRP session, the miniaturized hairs that were there started to come in and give much more fullness. It looked a heck of a lot better. In our magnified lens, we can show patients that we find the same spot and we can see that change, that improvement in the hair coloration. You can see how fine hairs, miniaturized hairs, can become healthy caliber hairs. And if you find the same spot on a patient's head, you can actually track the progress hair by hair. Here it starts, this patient started with villus hair, sort of peach fuzz, that the coloration came back, it grew in longer, and it became full mature hairs over the course of the year. I'd say of all the studies, our protocol most closely resembles this protocol in terms of using an extracellular matrix, doing 2 PRP sessions about 3 months apart, and also really concentrating the PRP. We like to get, again, 5 to 7 times the physiologic concentration. And their findings and our findings, sort of ours are corroborated by what they found. The benefit is something they start to see really around 6 months later. 3 months it starts, but 6 months is when patients can start to notice the improvement, and it continues to improve. It may start to plateau at about a year. Studies indicate that about 20% of patients after a year, the benefit may start to fade, but other studies, and I would agree with this, show that about 14 months after the final PRP treatment, the benefit may start to fade. Now, there are certainly instances, and in our case I've seen this quite a bit, where 24 months after the initial procedure, patients are still benefiting from it before the benefit starts to plateau and they may require another procedure. But patients that respond are always going to be responders. They can always have another PRP session years down the road and they'll respond to it again. Now, PRP is not just for genetic hair loss. There's other dermatologic conditions where PRP can really be beneficial. We've seen it in our patients as well. Patients with LPP. We had a patient with biopsy-confirmed LPP, had 2 PRP sessions with us, and the hair grew back quite nicely. For cicatricial alopecia, scarring alopecias, PRP injection probably won't work in scar tissue. However, what we've found is that when PRP is used as an adjuvant for hair transplantation, suddenly the hair can take like it never took before. This is a patient who was misdiagnosed for many years and had cicatricial alopecia from a folliculitis decalvans years ago. You can see from above, it was really just a bald spot that was shiny, and from cicatricial alopecia, we used a combination of hair transplantation where the grafts were incubated in PRP and PRP was injected into this alopecia region. And 10 months later, the hair started to come in incredibly well. I can tell you that this patient continues to send us updates. This is 16 weeks after the procedure. Now 2 years later, after 2 procedures, the hair continues to come in, and something that bothered him tremendously and really negatively impacted his life is now something that he can feel great about. I'm a part of a nonprofit organization called the Babyface Foundation that performs pro bono surgeries on children who were born with facial and even scalp deformities. This is a young kid who had an ear reconstruction surgery years ago and left him with an unanticipated huge scar on the back of his head. Well, with PRP as an adjuvant, we're able to place hairs into that scar, and ultimately, area where there is no hair grows hair, and he can focus on more important things like basketball. PRP can also be combined with different topical measures. When combined with PRP, can have an incredible effect. Remember, PRP slows apoptosis. It helps stop hair or cell death and allows hair to do what it would normally do uninhibited. So these elements that stimulate hair growth will stimulate hair growth much more effectively when we've taken away those negative influences. All of these patients that really may not be great surgical candidates can be phenomenal candidates for PRP with any sort of topical medication. They can really benefit from that. This patient is someone who had a PRP session and a topical blend, responded tremendously. These are all non-surgical patients. But I can tell you, we have similar topical blends for women, and again, when they have PRP sessions and they can use these topicals, that really seems to have a synergistic effect in the hair returning to a very healthy state. But it's important that patients realize PRP is not permanent. It's something that can have a really nice effect, but it's very likely that the hair is going to someday return to its baseline if they don't do anything afterwards, and they'll probably need follow-up sessions. It's not going to be as profound of an improvement as a hair transplant, but it is something that can have a very nice effect as long as the right patient is encouraged to do it. As a physician, it's important to try to understand who would be a good candidate for PRP and who's not really going to benefit from PRP. How do you do that? Well, you can pull out your dermatoscope, or what we call a foloscope, and take a look at the patient's scalp. We look at what we call the donor area and the recipient area, the back of the head and usually the top of the head. In this case, you can see that what we're essentially looking for is miniaturized hairs. Miniaturized hairs are less than 20 microns, basically hairs that are a lot skinnier than their neighbors. When we see a high percentage of miniaturized hairs in the recipient area, that's helpful, but when we see hairs that are not in the growth phase, they're in the catagen or telogen phase, that's when a patient may be a great candidate for PRP. Remember, PRP is something that helps slow down apoptosis, cell death, and then hair death. So these hairs are being held back in a way, it seems. So I would say this patient would be a great candidate for PRP. This guy, not so much. This is his donor area. This is his recipient area. Yeah, there's a lot of miniaturized hairs in the recipient area. He may respond a bit to PRP, but his donor area is so healthy based on the caliber and the number of hairs per bundle that he would be a much better candidate for hair transplantation, hair restoration surgery, which is a completely different league in terms of the hair improvements and the permanency of hair treatments. These are all hair transplant patients of mine, and you can see with hair transplantation, hair restoration, we're able to really add density to the hair that's there. We're able to shape hairlines in a way with fullness that we would never be able to do with PRP. And surgery is permanent. The hair is not going to go anywhere. They don't need to worry about it anymore, because when you place new hair, into an area where there's thinning, that will continue to grow throughout a patient's lifetime. So it's important that patients realize there's a big difference between PRP, the duration of the benefit and the degree of benefit in hair restoration surgery. However, adding platelets and platelet-rich plasma to your armamentarium can really make a big difference as long as you and your patients understand there are limitations in terms of the way that the PRP is performed, which you now can optimize. Patients' expectations, you have to temper those with what I just mentioned. It's not permanent, and the effects may not be as profound as you would get from a surgical procedure. And choosing the right patients. It's important to be able to choose the right patients based on their miniaturization, who's going to benefit more than other people. And once you've done that, we can use our same analogy, and just like an expert card counter going to the poker table and entering right when it's the opportune moment, we can do the same thing by optimizing our treatment protocol by doing the following things. 1, really concentrating the PRP. You want to have 5 to 7 times the physiologic concentration of platelets. You want to activate the PRP using calcium chloride prior to injecting it. You want to microneedle. I like using something that's a little bit less than a millimeter, maybe 0.75 millimeters, but microneedling is something that can help release the growth factors in that area, and that has a positive effect on hair growth. I like to use Acell, an extracellular matrix, and the idea again is you want to prolong the release of growth factors. You want to control that release and prolong it. Many small injections. It's better to inject very little many times than to inject a bolus once or twice. If you can do it without using lidocaine, great, good for you. I do need to use lidocaine. I can tell you, because we have Acell, this white powder, in our PRP, we can't use a 30 gauge needle or it gets stuck. We use a 25 gauge needle to do the injections. I once tried to treat a patient without lidocaine and it felt like torture. I felt terrible. It was very uncomfortable for the patient, and I'm never doing it again. I always want to treat my patients with a local anesthetic prior to the procedure, so it's a comfortable procedure and they feel like they're just wearing an invisible helmet and it doesn't bother them. You want to do more than one treatment. You want to do at least 2 PRP treatments in order to have the real benefit, and they should be spaced 3 months or less apart. The studies that showed the most improvement did have multiple treatments spaced less than 3 months apart. Now, with this ideal scenario, with this ideal protocol, what can patients expect? Well, they can expect to see thicker hair, increased hair caliber, increased numbers of hair per bundle. 2s can become 3s, so on and so forth. Increased anagen phase. And what that means is if someone's frustrated by short little bangs that just aren't growing, well, if you can prolong the anagen phase, prolong the growth phase, those short hairs can become much longer and therefore thicker and fuller. Sure, an increase in keratinocytes, I don't think patients are going to care so much about that, but what they do care about is the perceived increased fullness and the perceived ease of styling their hair after PRP treatments. So again, taking all these things into account, what you now can do, if you do it properly, these patients that come into your clinic can come back looking like this. That is, unless if you don't care. Thank you.